Thank you very much to Jay and Byrne. It's my pleasure to invite Lisa Stewart, Senior Engagement Officer at the Patient-Centered Outcomes Research Institute, to talk to us a bit about how to strengthen the patient-clinician relationship and ensure patient care and quality well-being. Thank you.
Well, I'm not sure I'm going to deliver on all that, but it is a great pleasure to be here this morning. It's still morning. And I recognize I stand between you and a plate of food. So I'm going to be fairly brief in my comments because many of the points that I intended to make have been made over and over today. And I think that much of what I have to say is an agreement as opposed to something particularly new. It is a great honor to be here, particularly at this moment, knowing that the work that this collaborative has done is going to be a catalyst for change for generations to come, and really is about increasing the humanity of all of society, not just within the domain of healthcare. So my talk is going to be a little bit more personal in nature. And I'm going to speak less from my position as an engagement officer at PCORI. I will touch a little bit about that work, but more from the place of how I got to become a patient advocate. Because this isn't something that you set out to do necessarily. It is generally because of life circumstances that put you in positions that you have to stand up and participate in a different way than you anticipated. So my aim here is really for us to think very critically and expansively about how patients can be partners in this process of alleviating clinician burnout, taking from the handbook of patient-centered care and how patients have been involved as key agents in moving that along as well. So my journey started probably 11 years ago now, and then I received a call at 3 a.m., 2 a.m. in the morning, got to the hospital, was sitting with the attending who was telling me that my child, who had just been transported to the neonatal intensive care unit, was not doing so well. She was on an oscillator, and if things didn't get better, she would be placed on ECMO. And so, I didn't know how to interpret this. I had no references for these machines and the equipment and the interventions that were being discussed. And my daughter's dad and I looked at him and said, well, what can we do? And so our attending said, pray. And so in that moment, 11 years later, I still remember that because that was about building connection. And so what he shared in that moment was a window into his inner self. The same attending on days when my daughter's dad wasn't doing so well emotionally, he held him and he shared tears with him. And he talked about the successes that he had had in his career with patients like our daughter. And he talked about also the possibility of a different outcome. And it was through that we experienced a commonality with one another. So someone mentioned earlier about the brand issue. Will this issue of clinician burnout really resonate with others because of the privileged position that people see providers, clinicians being a part of, that class? And what I can say to you from my experience of being a carer, as well as being a patient navigator and family navigator, as well as being the leader of a patient and family advisory council at our hospital, is that yes, because the connection that we feel is a human connection. It is beyond class and notions of privilege. So it's hard for me to do two things at once. Okay. So I, too, recall a second experience as a patient navigator. I was brought into our health system after our daughter's doing well. She's 11 years old. But she had a rough beginning. And she was in the hospital upwards, in terms of admissions, upwards of 12, 13 times after a very lengthy stay in NICU. I was the patient family member who showed up at grand rounds. You know, I was kind of everywhere. And one day, her pediatrician invited me to think about becoming a navigator. And through our conversations, what I learned was that her pediatrician also had a child, different in his presentation, but was clearly going to be not able to live independently over the course of his lifespan. And so, again, another point of connection. She knew what it was like to share some of the same troubles and challenges that the family members that I worked with every day as a peer navigator understood, the strain that it placed on families, the strain to perform her job to a certain level, plus with all the demands that have been expressed here that are other drivers of clinician burnout. But what patients can add to this conversation is a word that someone mentioned just, I think it was you, Jad, about empathy and really having a sense of understanding about what it's like to be in crisis, what it's like to have expectations placed upon you, what it's like to be within this web of forces that aren't always designed to assist you in doing what you intend to do. So much as we talk about the social determinants of health, and we have to think about that it is not, as we were discussing, or as was mentioned earlier, about individual character flaws, but it's a much wider issue of forces that are working outside of the individual. So engagement, as I recall engagement being discussed within care settings, was really about how do we engage with patients and activate them to be more interested or able or prepared to work as partners in their care. So I want to kind of level set and talk about how we talk about engagement in patient-centered outcomes research, because it's a different angle. It's about how can we involve patients and other stakeholders as meaningful partners and collaborators, and not just to validate what we're doing, but to bring them in at the beginning to help think about what the research focus and question should be. How should the study be designed? How to get them involved in data collection, analysis, and ultimately dissemination and implementation. So in this paradigm, patients are partners, not just subjects or research participants as we prefer, but partners, collaborators. And undergirding this is a set of principles that may be aspirational when we think about operationalizing them, but really could be touchstones to think about how do we build these relationships, because they need to rest on something. And for us, our advisory panel on patient engagement helped us think about that it should be about mutual benefit, reciprocal relationships, co-learning, transparency, honesty, and trust. So there's a lot of common ground between the discourse of patient-centered care and patient-centered research that I think are starting to form some connection points in interesting ways, which we are really glad to see. And I can tell you, and one of those connection points are what has been expressed as similar burdens, if you will. So in patient-centered care, as a physician friend of mine was just telling me this week, when I was talking about patient-centered care, he thought of the burden of it, the burden of delivering, not necessarily being an opposition of it, but again, the administrative issues, which caused him to have less meaningful time with patients, lost agency in the way that he wanted to practice the art of medicine. And where do we find these patient champions that we can involve? Like, where do they exist? And in patient-centered research, we have the same conversation and the same reaction from researchers around these perceptual challenges and real challenges that it takes too much time. It's too hard to engage. Where do we find patient partners, and how do we do it when we have them? But what we see on the other side of this equation, once the research has been completed, are a shift in mindset around the benefits of engagement, because now we've had the experience of it. And what we hear from researchers is the feeling that the research is more relevant. It changes the mindset about research. We frequently hear that we'll never do research again, how we used to do it. And so they build it into their how they structure their future research. So I challenge us to think about how that may play out within this space as well, where we're met with oppositions or focus on the burdens and challenges to implementing, how we can actually turn the tables on this based off, and we've heard that today. Okay. So again, common ground that clinicians and patients have. There's a shared value system, clearly. I really appreciate the term person-centered care, because under that we have the fullness of the tent. We have everyone under it. So as the person behind me today was talking about, that she's not only a patient wellness director, is that right? But also clinician and patient are brought together as part of the same concerns, and that there's overlapping priorities that are shared between the groups. So I want to just throw this out as a case example of where mutual benefit of a circumstance where people were not necessarily happy to incorporate patient-reported outcomes, as which this project was about, because they saw it as an additional burden, right? Taking more time and representing an added step in busy workflows. But what they found in Partners Healthcare, after conducting 25 qualitative interviews with physicians and non-physician providers, as well as a huge data set of over $1.2 million PR data pieces that they collected, that there was actually a perceptual shift occurred, that PROs or pros were actually believed to help improve relationships because it facilitated new conversations. There was a better understanding of patient symptoms. There was enhanced shared decision-making. And in fact, the screening tool, because it was often used in the waiting room during that period, it actually increased the efficiency of the visit. So again, another instance of where mutual benefit can occur, even though there's a perception of challenges that may have gotten in the way. So I want to, as a wrap up, I want to just spotlight two activities that have occurred, or organizations that are working in this space already. So as you think about partnering and finding patient champions, that there are organizations in place, patient advocacy organizations, that have this as one of their critical concerns. One is Plaintree International, and some of their work aligns with the goals of creating, the recommendations of creating positive work environments and reducing stigma and eliminating barriers. And what they have created is a care for the caregiver program with the broadest sense of the word of caregiver. They have a person-centered care certification program where people can train on how to better support changed work environments. They've developed a burnout risk assessment checklist for providers and a quality burnout assessment tool for organizations. Another organization who has a critical interest in this area is Patient and Family-Centered Care Partners, and around the recommendations of creating positive work environments and creating positive learning environments. One activity that they did not too long ago was to ask their patient and family advisors for input on how can patient advisors positively impact physician burnout. So of the responses, the themes fell into the buckets of, kind of low-hanging fruit. We could do more around provider appreciation and recognition. We could create some programs around that, some initiatives around that. We could assist with patient and provider communication training and certainly be supportive of provider wellness initiatives. Also, that the Institute for Patient and Family-Centered Care is also very interested in this as well, as the Institute supports the development and of patient family advisory councils at hospitals. So PCORI has an extensive portfolio in improving health systems. And what I really want to draw out here is, as many of you know, that for PCORI awards, engagement has to be embedded within the research. So again, from very early on to the very end of the study. This quickly is a study that was done on clinician burnout. It was looking at stress reduction, so just, again, one area around resilience, but clearly not dealing with the larger systems issues. But here, the patient and clinician stakeholders who were involved on the research team helped refine the research question, was involved in study planning and the recruitment and retention, and co-facilitated focus groups, as well as did data interpretation. So in closing, considerations for patient engagement, again, involve patients and consumers throughout the process. Think about it not just on a project level, but on a systems level. Prepare stakeholders for engagement. We can invite people to the table, but if they're not prepared to participate, then they won't, and they certainly won't in an optimal way. And provide feedback on the impact of contributions that people are making, and be very conscientious about setting up the infrastructure that is needed to support patient engagement. So on that note, I will close, and I thank you. And Charlie, do you want to make some final remarks?